I wanted to make a video on autonomic dysreflexia. This is such an important topic to understand and to be able to explain to our patients since it's so life-threatening. And so I thought if I kind of went through the process, maybe it could be helpful I know it helps me, so maybe it could be helpful for someone else. So what we're seeing is whenever there's a level of injury above T6, so where T6 is pretty much our cutoff. And so we'll talk about it a little bit more later, but the T6 or above, you see an injury there, and then you're concerned about the potential of someone having autonomic dysreflexia. So generally you're having some kind of noxious stimuli, right? So the bladder is the most common, bowel and bladder. So the bladder is distended, it's filled, it's overfilled. They can't feel that, but you know when your bladder is really filled up, you have pain. And so that pain is telling the body you need to do something. Well, they don't feel that sensation, but their body still feels it. So what happens is it tells the sympathetic system, there's a problem here. We need to do something about it. And that information goes up the spinal cord, but it can't continue on up. So what happens is it then goes and tells the sympathetic system activates. And what the sympathetic is innervated, T5 through 9 innervates all the gut vessels, the major blood vessels in the gut. So what happens is that sympathetic system tells all of those blood vessels, you need to constrict, we've got a problem, sympathetic system is being activated. Now, all of that constriction is resulting in the blood pressure going up. And it doesn't just go up, it shoots up. So our major concern is the impact on the body from that major increase in blood pressure because all those major blood vessels have constricted and now we have a very high blood pressure. Now, that hypertension goes to the baroreceptors in the carotid sinus, right? Baroreceptors in the blood vessels detect that hypertension crisis. There's a problem, something needs to be done. And that message then goes to the vagus nerve. So the vagus nerve is parasympathetic, right? Parasympathetic nervous system. So the vagus nerve is like, okay, we've got a problem. Let's all try to calm down and let's try to implement the parasympathetic nervous system to try to counter this high blood pressure because it's so devastating. So what the parasympathetic nervous system does is it slows the heart rate. So the parasympathetic slows down the heart rate, saying, okay, if we slow down the heart rate, then we can start to control the blood pressure. And then it also tries to send descending inhibitory signals down to try to get that communication going through. But now the spinal cord, it's not communicating. And so it can't go down and take care of this component down here. So what we end up having is the low heart rate because the parasympathetic nervous system is activated above the injury, and we have high blood pressure because the sympathetic activation below the injury. So the parasympathetic nervous system above is where we get the flushing because you have vasodilation. So you get the flushing above the level of injury, you get the pounding headache. So we get those symptoms immediately, we can see right away. The sympathetic system is constricting the blood vessels, causing that increase in blood pressure. So one of the most important things is to check their blood pressure. If you're starting to see some of these symptoms or they complain of the pounding headache, first thing I would do is sit them upright, right? Sit them upright to try to lower the blood pressure. They don't have the muscle pump, so sitting them upright, not laying them down, sitting them upright will have the blood just drop down. And hopefully that will lower the blood pressure. But we need to check the blood pressure. If we're not seeing anything happen, we need to check the blood pressure because that's going to be our kicker. Because a lot of our patients with a high level spinal cord injury, we're looking at 90/50 as their typical blood pressure. And you can see 220/140 if they're having a dysreflexic episode. So sitting them up, checking for kink catheter, contacting nursing so you can get them down to the unit to make sure that if they have a suprapubic catheter, we have someone who can clear that, or if there's a bowel impaction, that can be taken care of. If nothing else, sometimes I'll straighten their clothes out in case some clothes got pinched during a transfer, if it happens immediately after a transfer. Looking for if there's pressure sores, any kind of ingrown toenail, or if they happen to be driving a power chair or hit anything, checking their feet to make sure that there isn't anything broken. And then they'll they'll confirm that there isn't anything internal going on, because the body is definitely having this autonomic response, and it is significantly dangerous. So again, hopefully just like the concept of it is helpful. When you're talking to your patients, there's a disruption in the brain talking, being able to talk and control the body because this pain is occurring. And so they really need to be able to instruct a third party. So your goals are them and being able to instruct a third party in sitting them up, and the key things to check, making sure they have a card. Christopher Reeve's Foundation has a really nice card that they can have in their wallet, because a lot of people in the emergency room, they're not aware of this. And so they don't know what's going on, and they'll try to lay them down, and which will increase their blood pressure more. So we're trying to prevent that blood pressure from going any higher while we figure out what's causing it, to get everything to go back to regulation. And once you figure the trigger out, it calms right down. So I hope that was helpful to you. Just wanted to share that. I worked really hard on my little chart thing to try to just walk through it. So just wanted to put it out there. All right. Thank you.